And I would like to thank Emily Navetta for joining us this evening and presenting to us again. She's been very good to us and presenting to us in the past. Emily is the Director of Managed Care Partnerships at Caregiver Homes. Through her work in payer and provider education environments, Emily has spent 20 years focused on community-based care delivery models and measurements. She led the development of care pathways for disease management initiatives in home health, incorporating infusion therapy, pharmacy, and therapy services. She's developed provider networks for integrated systems, including transitional care, behavioral health, and orthopedic bundled services. At Caregiver Homes, she is responsible for ACO and provider collaborations. In 2019, Emily presented at the 10th Annual Massachusetts Community Health Workers Conference, the 38th Annual Massachusetts Brain Injury Conference, the 30th Annual Case Management Society of New England Conference, and the Tufts Ethics Symposium. Thank you for presenting tonight, Emily.
Thanks so much, Doug. And it's really great to be here with you all. I'm so happy to be with you, be able to still continue to exchange ideas. I think it's very important through these times that we're able to still spend time together, integrate the care and work that we're doing, connect to each other in whatever environment that may be. So I really appreciate this opportunity to be here with you all tonight. If you have any questions, please do type them into the chat and we'll try to cover them. If you have any problems hearing me, just relay that, please. And let us know if you're having any technical problems. Caregiver Homes is a mass health provider of a benefit known as adult family care, which enables caregivers in the home to receive support, education, resource identification, and care coordination through continuing long-term services and supports. Okay, good. Thought I was going to have a technical difficulty there. Today or tonight, we are providing a framework for initiating collaborations with physical, behavioral, and social services impacting health, and to provide you with resources to get you started in this integrated care dimension. You may have noticed in the past 6 or 8 weeks that you are connecting via telephone with people who you hadn't normally connected with. It's changed our communication, the way we look at care coordination, I think, in these 8 weeks. I've tried to update this conversation to include that, but also to look at this as an opportunity for us to incorporate best practices, the kinds of things that we're learning about, the connections that we're making. I don't know about you, but I have found that when I'm talking to someone and giving a patient update and their dog or their toddler or their husband walks by, it creates a different kind of relationship, but it actually fosters better kind of communication between us because we're just getting to know each other better. And so I hope that we take advantage of this time and bring it forward with us to establish some really great, compassionate ways of providing care coordination with each other as care partners. By way of background, I think you all realize, we work in a historically industry-supported fragmented care delivery system. Traditionally, we are structured by specialty, very segmented, inpatient, outpatient, specialty, primary care, which is really misaligned with the holistic approach of addressing patient needs in a whole manner. In fact, we think in Massachusetts, because we have so much high quality healthcare and our hospitals are academic medical centers, that we kind of rise above the fray. But you'll note that Massachusetts ranks 35th in the nation on quality relating to coordination of care. And in 2018, the Commonwealth Fund reported that readmissions and behavioral health unmet needs were Massachusetts' worst quality indicators. So there's definitely some work there for us to do in order to streamline the care coordination among all of the care partners who are involved in patient care. We forget that healthcare is one of many competing priorities and is often put on the back burner when compared with the long list of things that are really on our patients' minds. We need to acknowledge that other life factors require us to consider clinical needs with patient engagement and satisfaction to meet their entire experience. If we put together a great plan and we think it's going to address all of their patients' needs, but we haven't taken into account what patients really need or what they require for their environmental settings, it's not going to work in terms of patient satisfaction, in terms of patient status, patient engagement, or health outcomes. In the early 2000s, the concept of holistic care rose, and the impact of co-occurring illness and social circumstances influencing health status led to a rise in preventive care. Health and wellness programs were established in the workplace. HMOs established primary care doctors as gatekeepers for specialty care, and there was a recognition and understanding that patients needed to be involved in the creation of their care delivery plans. One of the ways that health policy experts and analysts were trying to establish improvements is to identify gaps in patient care delivery and access. Access is one of those big areas where we can identify a quantitative way of determining if patients are getting what they need. Area deprivation is the easiest measure to identify risk. And just so you realize, deprivation doesn't just consider household income at all. It also includes social impactors like food, access to education and employment services, housing, digital services. Do people have Wi-Fi? Do they have telephones? Income disparity rather than income as a measure of household access and ability to services. And transportation, measuring all those other things that impact somebody's well-being. Not just their health, but their well-being. So there are lots of different ways for you to determine area deprivation in your neck of the woods. I'm giving you this, this is the neighborhood atlas, and you can put in any zip code. This is obviously the entire state of Massachusetts. You can narrow it down to specific areas. Health centers utilize it in their catchment areas as well. Log on to the website. You can make these really nifty heat maps, and it also will detail to you what areas of social impactors are of particular need in a particular area. And you've got the website there. And it's just an indicator for you of things to consider when looking beyond the four walls of the health center or the hospital or the primary care or specialty care practice that you work, to consider other factors that might be impacting your patients. I think we all would acknowledge that we now realize the importance of asking patients and families deeper questions about their lives beyond illness. These needs are what we term the social determinants of health. And the World Health was really responsible. They were the first entity to define what the social determinants of health were. That initial definition was begun in 2003, and it was incorporated into the CDC's Healthy People Objectives for 2010, and the list has grown. So the list started kind of narrow, and it has subsequently grown and continues to grow and evolve. So now they have incorporated things like early childhood experiences and development, which will impact health status right on through adulthood. They have talked about things like access to safe drinking water, clean air, and toxin-free environments, post-traumatic stress exposure, the environment that is surrounding families, exposure, availability, and access. And the most recent recreational and leisure opportunities, which you'll note is something that even in the pandemic has been quantified as an objective that people require. So you'll note, interestingly, that Governor Baker also frequently speaks in his daily press conferences about the ability to open parks. We need to be physically distant, but we also recognize people need a place to go, to breathe clean air, to expose their faces to a little vitamin D and sunshine, and to get some exercise. And in fact, in New York, they are now closing streets to enable people to gain access to streets to have some outside activity. So I think it's interesting that that's now recognized as a social determinant of health. It's commonplace for providers and patients to recognize the relationship of behaviors, environment, social determinants, and healthcare delivery on overall health status. Other drivers in total, actually, are collectively more important to healthcare services in terms of health outcomes than the healthcare access to care and quality of care that is actually delivered onto people. So that's, I think this is a great sort of picture of the impact of each of these representing into the overall health status. But interestingly enough, even the quality of care received is small in relation to other factors that impact healthcare. The Affordable Health Care Act of 2010 brought healthcare to the policy forefront. It was an interesting amalgamation of politics and legal administrators coming together with healthcare experts to try and gain consensus among providers and politicians to make decisions around healthcare. It led to an interesting sort of controversy about ethics in healthcare as a limited resource and how to measure outcomes and determine provider success. And in fact, what is success? Who is accountable for that success? Who is responsible for making sure that patients receive health screens and services that they are eligible for through their benefits? How do we make sure that people are aware of what those services are? How do we make delivery not complicated? How do we make sure that access is not complicated? And how do we balance population health versus personal health? And if ever there were an example of showing that need to balance population health versus personal health, I would call it part of the COVID-19 challenge. How do we balance those needs of individuals and individual patients with that of the public's health? So we are in a new world. We all talk about this new world order frequently, you know, with technology and other things, but this really is a fundamental change right now that we're experiencing in patient care and delivery. Certainly the impact of telehealth has been fundamental. There is a big concern that if patients are not interested or able to access their telehealth visits for wellness and specialty services, there will be a tremendous backlog of neglected health needs when and if this crisis ends. That will be another public health crisis following the pandemic. We all heard in New York City where patients were so afraid of going to the hospital that heart attack patients and stroke patients were dying alone at home for fear of calling 911 and going to the hospital. We need to make sure that telehealth becomes accessible to all. We have also learned a lot about disparities in just terms of access. Who has a smartphone, who has Wi-Fi, who can enable telehealth, who can understand how to access these visits. So that is a huge area of improvement that we need to focus on. And then what about things like confidentiality? How do we make sure that our telehealth visits are conforming to the patient confidentiality needs of our patients when there may be other people in the room, they can't get access alone. Maybe we're asking for contact tracing and they're not in a position to be able to share with us who they have been in close personal contact with because they are not able to have that conversation alone and in privacy. Are we what is our ability to enforce isolation or quarantine orders or recommendations? How do we handle communication with folks who are in a different location during their quarantine? How do we make sure that they're getting all of the needs that they have and that we are meeting all of those needs? What happens after they return to the home? And what kind of model will all of this be for improvements? How often do we really need to have our physical hands on our patients? Is video conferencing going to cut it for us in the future? Does this provide access now to patients who have mobility limitations? And is it an improvement for folks who are in rural environments so they don't have to drive 2 hours to get to a provider's office? How do we balance all of those things to make sure that in the end we are providing successful healthcare delivery? This is from the middle of April, so in the world of COVID, it's not as current. It was the most current I could get for the ambulatory visit declines. So you'll see such a drastic decline in the number of patients who were receiving their ambulatory visits. Health centers were recording something like a loss of 65 to 70% of patient visits at the end of March through the middle of April. So we need to think about how, after this crisis, can we make services be utilized and accepted successfully. And we all know, I don't know about you, but I've certainly gone through quite a learning curve through all of this myself. And so how can we help our patients through their learning curve as we develop these new norms? So I think expanded telehealth is going to be a big piece. The expanded notion of providers, this has been really interesting to me. The rise of the community health worker and the outreach team. Who's doing contact tracing? How are we training people to do contact tracing? Would we consider folks from departments of public health partners with us in care provision, and how do we incorporate them now into our network of healthcare delivery partners? And any of those outreach workers. We know that Mass Health, for example, is working really hard to make sure that navigators are still available. But it's hard when there's no person to go to at the health center or at the hospital to help with patient access. Are those going to be expanding our idea of who care partners are? How do we address disparities? One of the things that was very quickly apparent during the pandemic has been healthcare disparities. We need to address this in the future. How are we going to make sure that everybody receives the kind of outreach, communication, and education that they need to be able to share precautions and keep folks healthy? What about the new risk that we have about vaccinations? We know that there's a huge problem with kids not receiving their timely vaccinations because parents aren't able to get them into the offices to see their providers. What about the number of folks that we're going to have after the pandemic who come out of ICUs with ICU syndrome and long-term, possibly forever in their lifetime health needs, to make sure that we address all of the long-term side effects of their days in the ICU or in the hospital? Are we going to enforce forced vaccination for any vaccine that we establish for COVID-19, or forced treatment modules? How are we going to respond to all of the ethical challenges that this pandemic leaves in its wake? Those challenges will be addressed by making sure we adhere to this notion of a proactive approach to hearing patient voices, incorporating patient preferences and input of the patient's values and desires into treatment plans to improve health status. And this triple aim, which started in 2007 from the Institute for Healthcare was a framework that was established and has continued to evolve, and now recognizes that the patient is central to care delivery among all of the providers who share maybe financial risk, who share quality information. It's an era of predictive analysis that we're in right now to identify what we term rising risk. So we don't want to just focus our care on those folks who are ill and presenting to us, but to identify those folks who are on the precipice of being ill, that we can hopefully reduce the likelihood of them becoming ill or exacerbating their illness or developing more serious illness. So it's really to proactively challenge us to figure out how to put into practice treatment modalities to identify rising risk and make those needs addressed. How do we do that? This is very difficult. This is our challenge. And that's what we're trying to talk about today, is integrating other care partners, folks who we didn't necessarily traditionally envision as care partners, into our posse, into our group, to be able to tap into their knowledge and their expertise to be able to treat our patients. One of the most rich and enriching ways to identify care partners is through the community health needs assessments, the CMSNEs in Massachusetts. These are folks through local hospitals and local providers, pediatrics, behavioral health, substance use disorder, VNAs, community action, community hospitals, case managers, who meet on a regular basis and try to establish a local picture of what the clinical needs are, the social determinants of health drivers and providers within a local area, to identify gaps across the provider continuum and establish partnerships and networks. I strongly, strongly urge you to get to know your local partners already in place and available to help you through your CMSNE. You can go, if you just Google Community Health Needs Assessments or CMSNE, and input your town or your local hospital even, masshealth.gov or mass.gov will show you all of the local CMSNEs by area, and you'll be able to find yours. I've got the website on the bottom of this slide, and you will have access, or if you don't already, to these slides so that you can find your local CMSNE. I strongly urge you to connect with them. You don't have to necessarily build something new, you just have to establish those bonds and get to know who your local care partners are. There are lots of folks out there in the universe available to help. Clinical navigators are those clinical professionals to help coordinate services across providers for ease of patient movement, to make sure appointments are lined up and make sense. You know, your nutrition consult follows your GI, your blood labs follow your primary care visit, to make sure everything is aligned for patients who are starting to require more complex care coordination based on diagnosis or need. And then the care coordination navigators are those to help with resources in conjunction with medical services. So they could be care coordination navigators through SHINE counselors, for Medicare services, or through Mass Health, through like Healthcare for All, or other services, including Mass Rehab, the DDS, DMH service coordinators, elder services, community action, other navigators to incorporate social determinant needs into any care needs that may be being experienced by the patient. And I love this case study because I have a very recent update on our friend here. This was a gentleman who was homeless and was an active substance use user, and was admitted to the emergency department for a cellulitis. He was actually at Lowell General, and following his amputation, it was very, very difficult to find a SNF, a rehab facility, who would be able to coordinate his pain management needs with his active substance use and wound care. And then, of course, what were we going to find for long-term needs for our patient after rehab, due to the fact that he was homeless, and temporary shelters in the state tend to not enable active substance use users to enter into housing. We were very fortunate. He was part of an ACO, a Mass Health ACO, and so we were able to coordinate with that care coordination navigator. We were able to find shelter for him in the Tewksbury State Hospital after his stay in a SNF in the Stoneham area that could address his pain management needs with his substance use. We were able to connect with his behavioral health community partner through Riverside and get him connected through NAMI, the National Association of Mental Illness. And I am happy to report that the most recent update is that he is now a peer mentor with Riverside, and he is really thriving in that role. This pandemic, of course, has been incredibly challenging for folks with behavioral health needs, particularly those with substance use histories, and he's really thriving right now in that peer mentor role. So a great update. And this was an example simply of that SNE, that community health connection, to be able to include lots of different partners. This was a really complex situation where it was moving fast. You know, you have a discharge date, and then what? And then you have a SNF discharge date, and then what? And everybody really pulled together for a really great outcome. When you are considering other partners for collaboration in establishing a partnership or working with them, it's really important for you to be familiar with their operational process, of course, and their areas of expertise. I urge you to ask those difficult questions in order for you to establish really good partnerships. What are their challenges? What gaps are they trying to serve? You don't need to reinvent the wheel. It's really important that everybody has complementary services that they're providing to each other, and that they work together for the best of the whole picture. So what is your workflow process? What is your communication? What is our communication going to be? Who's going to be responsible for communicating with the physician or with the family or directly with the consumer or the patient? Do you have a universal consent form that we can use? Are you accredited by anybody? What are your quality mechanisms? Before you consider your partnerships, you want to make sure that you are confident that your services will mesh, that your referrals will be addressed, and that you will receive communication following any referrals that you make. And I can give you this case study. I like to use this case study whenever I review it with folks. I get lots of input and helpful feedback, because this continues, this family actually continues with us to be a long-term services and supports family. And I think that the language barriers represent challenges for all of us, but I will tell you that particularly in the age of COVID, we are experiencing a lot of interesting challenges with language lines. So I don't know if you have experienced challenges with waits and just getting language lines for translation services. It's been very challenging for us to be able to do that. And so, you know, it raises a lot of questions. This was a 52-year-old female patient with language needs in Arabic. She was at the Leahy Clinic, being discharged with a pretty complex treatment plan, discharge summary with a lot of VNA and DME needs, going home into a 3-generation home. And we continue to have interesting translation questions from the family about why the family would like to know why it is we can't utilize a family member or wouldn't consider utilizing a family member for our translation services. And I'd be interested in any conversation or any feedback that folks can share about how they respond to those kinds of questions I think there's a lot of cultural competency that we were seeking at the beginning of working with this family. And in fact, we were able to identify this great research, which has been incredibly, incredibly useful to us. I'd like to share it with you as a resource for you, and certainly welcome any ideas that you have. But particularly in this age of COVID, but even moving forward, how you're resolving any of your language needs would be really interesting, I think, as a next level case management conversation for us. In terms of establishing your relationships with other partners, I think a great place to start is with their code of conduct. Here's my plug here for CCMC Code of Conduct and the CMSA standards of practice. You can see I write a lot of notes on mine, and I'm always taking notes because I'm comparing care partners sort of priorities and their guidelines with ours, so that I make sure that it dovetails and they're answering all of the questions that I want to make sure that we address, and that we are a cohesive team. But I would recommend that you ask any partners who you're considering working with if they would be willing to share their code of conduct or their standards of practice for you to be able to take a look at and share whatever yours may be. It may be your mission statements, whatever it is that you utilize to make sure that we are aligned in the services that we are going to be providing, and that our guidelines help us to connect and use those guidelines to forge relationships, to gain insight from care partners and what their priorities are. In terms of meeting patient needs, our goals, of course, are to maximize patient engagement and involvement. I think that this continues to be an area of struggle for us in collaborating treatment plans into one cohesive plan that incorporates clinical, social, environmental, and personal goals. It's so challenging even to know who the other care partners are. I work a lot with Mass Health, and they have an eligibility verification system that will list some of the care partners that a member is involved with, but not all. How do we make sure we're not duplicative in the services that we're providing? How do we coordinate our services so that it's not duplicative? If I'm completing an assessment and a VNA is completing an assessment and an ACO is completing an assessment and not providing any immediate benefit to our patients, then we're just going to end up really turning them off to establishing any kind of level of engagement with us. So how do we realistically incorporate all of the services that we're doing to make sure we're not overlapping, but we are in fact not leaving gaps in the needs of our patients? And in order to do that, we first have to identify and prioritize patient needs. This is a really also controversial ethical thing, I think, in case management activity right now in the forefront. Interestingly, recent studies show a lack of evidence in any success in wellness programs that were initiated. We have a lot of workplace wellness programs and meditation and yoga and better breathers and all kinds of things, but they haven't shown to be drastically effective. And could it possibly be that we never really asked people what it was that they wanted, but we rather kind of formulated these plans and put them into place? And so now there is a interest in developing assessment tools to funnel patient services based on their needs. Now, this is kind of a nascent field. We haven't really established best practices on how to administer and even utilize the data that we find, but they're looking at coordinating multiple services. So for instance, prescription refill rates. We know whether our patients are filling their prescriptions or not. That was one of the high priority things that we were noting in the COVID crisis. If folks were afraid to go out to their pharmacy and their pharmacy didn't offer delivery, were folks getting their meds. That was a really key, very simple fix for us to try and establish, whether changing over to mail order or delivery, or coordinating some kind of delivery mechanism for people to get their medicines. And that was actually established by telephonic outreach in terms of what barriers are you having in the midst of COVID right now for you to stay healthy. So we're learning a little bit more. Can it be a telephonic stratification, or does it need to be face-to-face? How do we establish trust so that people will share what their barriers are? Can we always provide a resource for it to be worth the investment of our patients' time to have these conversations with us? Are we able to address language, gender preference, hearing impairment needs, all of the needs that patients may have in establishing communication with us, so that we're making sure that we are able to really hear what they're telling us their barriers might be to staying healthy. When conducting and administering any kind of assessment, again, this is a new field, so we're trying to figure out how to monitor over time. So you're measuring changes. Maybe somebody had food insecurity, but we were able to establish a SNAP connection and connect them to food pantries. So now we need to reformulate and evolve our assessment and make sure it's a continuous process. Make sure that we are evolving our treatment plans as their needs evolve, and not just to concern ourselves with the high utilizers, but those for whom impactful changes could avoid adverse events, and to capture patient interest, to make sure that the needs and the assessments are relevant to the needs that our patients are experiencing. So these are just some examples for you of things to consider when doing a screen or assessment. We know another interesting thing about COVID is how prominent childcare needs are in terms of getting people to be able to go about their daily lives. So that's been kind of an interesting thing for me to learn. But also to consider and to ask about workplace hazards, right? This is a really good time to know if folks are worried about exposure or other workplace hazards. Stressors, financial concerns, interpersonal, judicial, other concerns that we don't always consider, but really, certainly from pandemic days forward, need to make sure we're addressing to adequately meet healthcare and social determinant needs. This is another example of a sample assessment tool for you. This is from Health Leads. You see the website online. What I love about this is it's a universal screen, very simple, brief, that can lead to subsequent screening at a more high detailed level, but there are no literacy or language requirements. There's little pictures that can be completed. Also, folks can get tablets in their offices and share sites for translation services for lots of screens that come in many language. This is one from the American Academy of Family Physicians with a really strong social determinants focus, which I really love, that the practices themselves are asking questions around personal safety, utilities, and other services. I will tell you, it takes a village is cliche, but it has never been more clear to me than now how important it is to have all of these folks in your Rolodex and available to you as partners for helping address patient needs. We need services for stability in our communities. It's that simple. There's a rising awareness of the importance and value of long-term services and supports and home and community-based services. Certainly the congregate housing crisis that has resulted from the COVID virus now makes people very wary of congregate living circumstances and situations. What are we going to do to keep people safe in the community moving forward, and families confident that their loved ones are safe moving forward? This is an open question. This is something that we are going to have to resolve going forward. I don't think we're here yet, but I would urge you to get to know who the services and the providers are in the communities that you reside in and that you provide care to patients in, so that you know who to call when you have a need in front of you. The community partnership development is so important. Opportunities to incorporate long-term services needs for your patients can be done at multiple levels. It can be part of your pre-visit prep. It can be through any of your CHNA participation, but it's just so important that you make sure that you are addressing your local networks. I will say one of the untapped resources we've recently connected with are EAPs, Employee Assistance Programs. Always wanting to help folks out. You do need to make sure you're maintaining some confidentiality practices and standards, so you'll have to investigate that on a case-by-case basis. But other services in addition to EAP, other long-term services and supports are here on your screen. The Mass 211 has become phenomenal. Mass.gov has really stepped up during this crisis. There's housing, there's food, there's Wi-Fi discounts, really very excellent. The state COVID response at mass.gov has resources across the state. I urge you to check it out. It's really become a very robust and full tool. I'm happy to report. And other services, these would be family-based services available to you to connect with, certainly now as families are trying to determine what kinds of transition services or IEP services are going to be available to them now that schools are all home-based, and that we are not clear on what's going to happen in the fall. It's probably a good time for parents to start reaching out and determining what resources are available to them, and throughout the summer as camps are canceled. So families are going to need a lot of support in the next 6 months through the fall, I think, to make sure that their needs are addressed. Technology considerations, this is still very much, I think, to be determined. I can tell you that insurance companies have made incredible flexibilities during the crisis in terms of reimbursement for utilizing electronics and technology in health visits. So there was a lot of discussion about whether telehealth visits needed to be video or audio only, as some folks did not have access in their homes to be able to receive telehealth visits with video. So this is one of those areas still very much to be determined. We also have to figure out some consent and attestation, as people are saying, yes, I am in fact Emily Navetta, and making sure that we have some way of maintaining data and privacy. We have a lot of issues around social media ethics. People were using Facebook Messenger, making sure that business agreements are in place. But also, what about patient alerts, patient ping, people utilizing Alexa for medication reminders? We haven't really established policy and protocols that keep up with our technological advancements. So that is something that we really need to take into consideration when we're establishing our guidelines and being able to share with our patients what they can expect from us in terms of confidentiality and services. I have another case study here for you. This was a gentleman in the Merrimack Valley area with a very prolific alcohol problem. He stumbled on the street and broke his heel. And there were very, very complicated family dynamics that ensued, where he was not welcome to return to the home environment following his discharge from the hospital. There were very stringent pain management protocols that were put in place. And I will tell you, we discovered that through pain management, that an acupuncture team went in and met with him, and it was incredibly successful. It really worked for him. But in formulating a long-term plan for him, We worked with his employer for FMLA and his substance use disorder. Most of the barriers were not clinical in making sure that this gentleman stayed healthy for long-term needs. Most of this is a healthy guy in general, but he had many, many social determinants of health impactors. But he was a very strong, willing, and engaged patient. And so with his church involvement, with his employer's involvement, he was really open to all kinds of alternative mechanisms to get him back into the community on a long-term basis. And we really tapped into, through his employer, a lot of the services that were available from his company and his church to be able to get him safely in a home environment where he remains today as he's resolving his family issues. So quite possibly the biggest challenge in healthcare are the so-called super users, those with chronic and co-occurring morbidities. And they do tend to utilize the bulk of our time and our services and, quite frankly, our dollars. But as we've discussed before, social determinants have a major impact on outcomes. And that is true of the super users as well, not just clinical care needs, but other social factors contributing to outcomes. Quite possibly the fastest growing population subgroup are vulnerable older adults. And we have not yet really come up with a best practices way of keeping folks healthy in the community and to resolve the needs that our vulnerable elders have. And I think we are in the process of figuring out some alternative mechanisms, really stretching the creative impulse in terms of long-term services and supports for these folks. But they are, of course, open now. There's a big concern of neglect and abuse in the home, particularly during the COVID crisis. And so I wanted to let you know about this resource, which is for elders who are at risk for homelessness or housing, which is impacting their health. It's a great organization for you to connect with if you have any housing needs or concerns for any elders in the community. Massachusetts offers several managed care alternatives that utilize care management services. These are the so-called demonstration projects with CMS that started in 2016 through the delivery system reform incentive programs. These are the so-called duals or integrated programs, and they're characterized by case management models which coordinate needs on a case-by-case basis through both face-to-face and telephonic outreach. And these are case managers who are coordinating all kinds of levels of care for complex needs, complex care needs, as well as social determinants, literally on a case-by-case basis. And they have the opportunity to utilize what's called flexible spending, which is a really remarkable way of looking at a holistic patient needs. If folks have asthma and need an air conditioner, they are able to provide for financial reimbursement for someone to get an air conditioner. If somebody is having a bed bug infestation, they can facilitate services for that with housing officers. So it's a pretty great case-by-case way to make sure that care needs are met. Another managed care program is the PACE program for those otherwise needing nursing home placement to keep folks safe and healthy in the community. Also a very rich case management model that you may be familiar with. Medicaid reform is looking to standardize benefits and services across all of the Mass Health and Medicaid products or programs so that they will all be somewhat similar in terms of the benefits that are afforded across Mass Health. And the biggie, the 860,000 lives currently in Massachusetts enrolled in accountable care organizations, the ACOs, 17 ACOs across the state among different models. But the big important differentiator here is this new layer, these so-called community partners, which is a new layer of care coordination with long-term services and supports in behavioral health to determine and implement integrated care plans in conjunction with PCPs. So a community partner, whether it's behavioral health or long-term services and supports, will go in, complete an assessment, make recommendations, deliver those recommendations to the primary care provider, incorporate them into one treatment plan, implement those services, and make sure that the provider, the primary care provider, and any other providers are included in that plan to enable the member to have a lot of touch points to keep them engaged in their treatment plan and able to understand what services are available to them. Behavioral health is a big case management opportunity for us to engage our members. Depression and anxiety are no longer just accepted as an untreated consequence of chronic or acute illness, thankfully. I remember when my grandfather had a stroke and he was depressed, and his provider said to me, well, of course he's depressed, he's had a stroke. And I don't think that that is accepted anymore. We want to make sure that everybody is treated for any of the behavioral health needs that they may have. And I leave this statistic whenever I can because it's just so dramatic to me. Patients dying by suicide visit their primary care provider more than twice as often as people without suicidal ideation. 50% of people who die by suicide have visited their primary care provider within 1 month of doing so. So we really need to make sure that we're screening folks through primary care and any other way that we can to address any behavioral health needs that they may have. That would include flexible spending for behavioral health and treatment needs. We talked a little bit about flexible spending for health-related factors. This is a new idea to go into effect for public payers and quite possibly private payers as well moving forward to make sure that we are identifying and addressing anything that will have an impact on health status. Challenges to delivering comprehensive care delivery. We all live every day. PCPs are now responsible for all services that are provided to their patients, whether it's behavioral health, VNA, substance use disorder, and coordination with unfamiliar provider partners. I think that's pretty terrifying for our primary care providers. And so they, at the practice level, are now seeking ways to be impactful and partnering with long-term services and supports and other provider partners. And one of those big challenges for us to make sure that that happens seamlessly is the interoperability of data. Can we send a referral over through an electronic medical record, know that there is follow-up, be able to then connect to our patient the next time we see them, see how they're doing with that referral, and just be able to communicate updates with each other in real time to make sure that there are no gaps in service delivery for our patients. We're working on it, but I know that some hospitals themselves have 3 or 4 different electronic medical records, one for the ED, one for the delivery room, one for the behavioral health floor. This is still very much something that is in process for us, but we need to establish ways for our communication to flow, whether it's cut and paste, whatever Band-Aid it is, we need to make sure that we are all communicating with each other. Really, it's an imperative for us to have strong communication in whatever mechanism that is with our care partners. There is a lot of good professional evidence out there to show that care coordination approaches that are maybe non-traditional have been very impactful and worked out there in the community. The Baptist Hospital in Kentucky was the first to sort of identify and prioritize risk factors, and you can read all about their information online. The Camden Coalition, probably many of you have heard of, which was community-based delivery to get folks out of utilizing the ED as a source of urgent care or primary care. It's been very successful. and Stanford's coordinated care program, which is employee-based, and a new way of utilizing employees as care partners in our establishment of coordinated care. I would say that successful approaches include community-based care partners, whether it's respite for family caregivers, or just utilizing ways of keeping people successfully healthy and safe in the home. All of these services are available for folks in the community, and hopefully you're familiar with them and aware of them to help keep our families safe. I know we're getting to be on the time, so I'm going to try to finish this up with a COVID case study. This is very, very much in process. This was a young man with an incredibly supportive family who was referred to us a couple of weeks ago. But I think you will find his concerns relevant in any case management environment. A young man with very, very complex care needs. And due to COVID-19, he has found that all of his progress is really on hold, that his treatment has ended in many circumstances for non-essential services. There are long waits. He had a very difficult time connecting to his behavioral health therapist through telehealth because he and his family were kind of unfamiliar with how to navigate that system. And his PT and OT were on hold for 6 or 8 weeks, which made him very, very frustrated in the timeline he had established for improvements as he's preparing for some wrist surgery that he was supposed to be undergoing in the fall, which is now on hold. And so how do we respond to these patients? What can we share with them to keep them motivated so that they don't just fall into despair and frustration? What is it that we can do for these patients so that they continue to feel like they're moving forward and making progress in these difficult times throughout this pandemic? So that's just something for us to think about. I again welcome any comments or suggestions that you might have. This is a tremendous challenge for all of us, and maybe just connecting to each other, we can learn about what each other is doing to make sure that our patients don't lose any of their enthusiasm for their treatment. So looking forward, we talked about experience enhances best practices, and hopefully that is something that we can all look forward to as we move forward beyond this crisis. So, bubble up. If you have best practices, share them, promote them, make sure that care partners are aware of them. It's really important for us to make sure that we are utilizing any codes that can track the time that we are now spending with our patients telephonically. This was predominantly sort of an unrecognized use of our time. So now in the age of COVID, where there's recognition of the time required and it is reimbursable, I strongly suggest you to code accurately. So following the crisis, there's a clear representation of the amount of time that it takes for those phone calls. And again, I suggest that you get to know your community, your care partners. That's the best way for us to really initiate great patient care coordination, case management, and delivery. I think I made it. It's just about 7:01, and you will receive an email link following this workshop for your evaluations. We ask that you please complete your evaluations, and you will then receive your CEU credits. And Maureen, if you want to let me know if we have time, I'm not sure if we have time for any questions.
You have some time. I don't have any questions unless anyone else has sent anything. I know people are asking about the slides. At the bottom of your Zoom confirmation, you can, there's a link with the slides for tonight's presentation. So if you look at the bottom of the Zoom presentation link that you got, there's something down there, but I can certainly send it to you again. I do have a couple of people who I can send it to. All right. Anyone else have any questions? Oh, wait a minute. All right. I do have one from someone. It's, how would you navigate Medicare's new face-to-face requirement for a video visit with the PCP to approve VNA services.
Yes. So some VNAs have been utilizing various mechanisms. I think that some folks were utilizing Teams, Microsoft Office Teams. Some folks were doing attestations with, meaning they shared with their patient that this may be a non-confidential way of us having communication, and then noting it in the documentation that there was an attestation that the patient was aware that the video did not necessarily meet confidentiality, HIPAA requirements. I know that Medicare and CMS are releasing flexibilities through the crisis on a daily basis. I can't even keep up with them, actually. They're released every day across all 50 states. So I would say that you could, I think documentation is really very important. We've had some patients who there was no smartphone capability, there was no video capability. We are documenting and hoping for the best. That's not a great answer, and I don't hold me to it, because I don't know what the reimbursement will hold for that, but we're hoping that the flexibilities and the documentation align when this is all over, and that there is, I think as long as you're documenting that you tried, what you tried, and that the patient consented, I think that's probably the best you can do. Doug, you might offer some additional advice there.
No, I think that's fine. I think, it's definitely a learning curve for everybody. I think document it as best you can, work with your liaisons for your healthcare, your home care vendors, and see how you can best accomplish that.
There was another question, if the patient does not have a computer or a smartphone.
Right, and so then you would have to just document that it was a telephonic only, audio only communication and visit. You were not able to lay eyes on, so there may be some, standards and qualifications for eligibility that you were not able to confirm. But if based on the PCP recommendations, or based on what the patient is attesting to your best knowledge, that you were moving forward.
Any other questions for Emily?
No.
Well, Emily, thank you again for presenting to us. We truly appreciate it. We had a great turnout tonight, and thank you all for attending. Look forward to our upcoming offerings. We actually do have one more question. Are you finding that more PCP offices are placing case managers in their offices for high-risk patients to aid in care coordination?
Great question. Absolutely. Embedded case managers are now becoming the norm among primary care and health centers. Absolutely. For that very purpose, to keep folks moving along. My classic example was the nutritionist and the GI. We used to have so many patients who had disparate appointments, but they really needed to be, the GI would make a recommendation, bring it to the nutritionist, or vice versa. And there was just so much of a time lag that patients weren't able to really make the connection between what those two providers were sharing with them. Same with neuro consults. And so now we are absolutely seeing a tremendous rise in the number of embedded case managers at the practice level. And it's a great way of instilling collaboration with specialists, but also other ambulatory services.
Great. Any other questions before we go? I don't see any. Emily, thank you again. Thank you all for attending. And as I said, please keep on the lookout for upcoming programming that we're going to have. We will get better at this, and we promise to bring you great stuff in the future. Thank you. Have a good evening. Stay safe.
Thank you.
Bye, everyone.
Thank you.